Well, the venogram is the gold standard for looking at these veins. The venogram, you actually inject dye into the blood vessels and you take pictures of the vessels. And this is what Dr. Neville is going to talk to you about. And you'll see examples of it. The venogram shows all the vessels in all their glory. And it is a completely different study. There, you have to have a catheter put into the vessel, you have to inject dye into the vessel, and you have patients exposed to some radiation to get the pictures. So there's a little bit of risk just doing the procedure. And then the question is, once you see that narrowing, you can balloon it open. This is not a new technique. It's been done in blood vessels throughout the body, particularly the heart. So people have tremendous experience with. So opening up a blocked vein with a balloon is, as it goes, relatively easy procedure. The techniques are there, the aptitude is there, but the question is, does it help? And what are we doing to really follow how it helps patients? And that's where the devil is. For us, what we are trying to determine is, does that really help?
Are there instances where the veins have collapsed again?
Absolutely.
Talk about that.
I think there are, and I don't know the exact numbers, but a group in Europe that has several groups in Europe which have been the proponents of this theory, do report that a fairly large number of the veins, even after they've been opened up, will recollapse. And I think it's upwards of 50% in some
in MS patients?
In MS patients. And so the people say, well, rather than just opening it up with a balloon, why don't you put a stent in there and leave it open? And that way we'll hold it open. And the problem has been that that has been fraught with some complications. As you're well aware, at Stanford there were some morbidity and mortality associated with this.
And one traveling to the heart?
Right, because the veins are draining into the heart. So if you put the stent in the vein, well, if it dislodges, it's only going to flow into the heart. That's the natural path for it to go. So that's the question, is does this help? And is it worth the risk of putting in a stent? Now, we are not going to look at putting in stents. So our question is, number one, what's the extent that this exists? Number two, once we identify it, if we do open up that blood vessel, are there any benefits that are to be gained by this? And I have a whole host of endpoints that I'm looking at with our patients to try to decide. Some of them are subjective and some of them are objective.
What does the data show you right now that is based on? How many patients are you looking at that have done this?
Right, so we have 30 patients that have had ultrasound. Half of them have this, have narrowed vessels, have reflux. So very surprising, it's exactly what the group at Buffalo has found. We have done to date one venogram, and surprisingly that patient, Nicole, her ultrasound didn't look quite so bad. It was there was some narrowing, but the venogram showed there was a lot of stenosis there, a lot more than we expected. So the ultrasound underreported what we saw. We've done one, and I can show you the pictures.
You don't have to show me right now. We'll see it later.
Okay. But it was, again, one of these instances where there was blockage bilateral on both sides, bilaterally. And Dr. Neville was able to open up the vessels with a balloon. And now we're following her, and we're looking to see how is she doing. Are there changes neurologically? And there are known criteria that we follow, quality of life surveys, our physical examination, and there's some kind of novel things that we're looking at to determine, is the patient better? And then once we have enough patients in a series together, we'll then decide, is this a valuable procedure for patients with MS? And is the risk of the procedure worth any benefit, if there is any benefit?
Mary and I were talking a little bit about this. What is the risk-benefit? There is,
well, we don't know, because we don't know what the benefit is. We know all the risk, because we know the risk of the ultrasound, none. The risk of the venogram, there is some. The exposure, the bleeding, the risk of radiation. With the angioplasty, it's possible the vein could actually pop open during the procedure. So they're all bleeding risks. But those are all known, those are all quantifiable. What we don't know is the benefit, and that's the problem. And if you cannot tell somebody the benefit versus the risk ratio, how can you counsel a patient? So that's what we're trying to decide is there a risk? Can we measure it? And then we can tell people, if you want to do this procedure, number one, these are the risks, these are the potential benefits, and it's probably, in my estimation, not going to cure your MS. It's a part of treating it, but it's not going to cure. I think we have to set that expectation.
This probably will not cure MS. It will just help with some of the aspects of the disease.
We think.
We think, because it's too soon.
We don't know. It's too soon. Because keep in mind, half of MS patients don't have this. And so it's clear that there are other things that cause MS, and we know that. We can look at brain scans of patients that have inflammation that's nowhere near, these big veins, and so it's impossible that that's the whole answer.
As you know, the internet is both a wonderful and horrible thing.
Sure.
And this is all over the place. So, patients are clamoring like crazy. I understand there's a lot of talk. People are wondering. This must freak the medical community out of it, because you've got a desperate population.
Absolutely. First off, MS patients are very intelligent. They are usually young, very educated, and very knowledgeable, and obviously they're very interested in their own care. And so they are very active learners and are looking for things. So when something like this comes out, of course, they want to know, is this for me? Is it something I should pursue? And, as we've talked about, it's a known procedure. And so there's not a lot of unknowns about the procedure.
So what do you say to those people at this stage?
Well, we tell them what we just said, that number one, we don't know. It's a theory that we have to go into this gradually. We examine it, and then it may be that at some point in the future we will be more actively pursuing this for our patients. And even if we do, there's a high probability it will probably, if it's going to help a bit, but that we're always going to have other issues that we're going to have to take care of. That autoimmune component, the white blood cell component, that's not going to change once you fix the blood vessel. The white blood cells, once they're active, we still have to take care of that. So it's still going to require treating the autoimmune part with medications and other things. But it may improve quality of life. If that increased blood flow helps, that may help a number of symptoms. But more importantly, it may help kind of more on a long-term basis, because prolonged ischemia, prolonged lack of blood flow is not a good thing. And outside of MS, there are two diseases of the spine where we have poor blood flow through the spine that are caused very similar type of thing, occlusion of blood vessels. And those patients have very slow loss of spinal cord function over many, many years. So their legs get stiffer, they become unable to walk. And some of our MS patients in the latter phases of their disease have exactly that same type of phenomenon. So the question is, well, could that really be a phenomena of the nerves just dying off? Maybe because of this poor blood flow. And that's where I think it may potentially have value, is in that kind of latter part of MS. But that's really going to take a long time to sort out, and we may never find that.
What are your concerns with all this excitement and everything that's going on about this?
Well, the obvious concern is it's a procedure that anybody who has vascular background can do. And this is a vulnerable group of patients, and that they'll be taken advantage of. And that people will do the procedure, either one, not adequately counseling the patient, two, making claims for a procedure that are not justified, and then three, putting the patients at risk as part of the procedure, and then patients actually end up worse off than where they started. And I have grave concerns about that. We can't control how people are going to present themselves and how they're going to present themselves to patients. What we can control is what the potential risks and benefits are, and get that out to the community. And I think a lot of neurologists, myself included, have been skeptical of the whole concept, whether it has value in MS. But we need to, rather than just dismiss it, we have to examine it and then really figure out if it has value, and then say to the community, yes, it has value, or no, it doesn't.
Is this why Georgetown is doing this study?
That's exactly right. You know, we're involved in many clinical trials for medications for MS. We're involved with clinical trials looking at the natural history of MS. And this is a natural extension of what we're doing. We have the largest MS center in the metropolitan area. We have almost 2,000 MS patients, and it's part of our mission is to not only treat those patients, but to understand the disease and kind of move the borders of information to a new level.